Good morning, everybody. Over the next few minutes, we're going to discuss the role of MRI in addressing some of the challenges that we see in the prostate cancer diagnosis journey. Here are my disclosures. We should all now be aware that the way we diagnose prostate cancer is flawed, and the diagnostic process itself contributes to poor outcomes for our patients. So we can't confidently identify many questions that directly affect our patients' lives. Questions such as, do I have cancer? Do I have a cancer that will kill me? A pussycat lesion or a tiger? Has my cancer come back? How long do I have to live? And how do I avoid pain, particularly for the advanced stages? As patients progress from diagnosis towards death, there are unmet clinical needs at various points in the journey. Today, we're here to talk about unmet clinical needs at the diagnosis stage. Patients who present for diagnosis usually have a raised PSA or have had previous negative biopsy. And we know that about 30 to 70% have cancer as a background of variable genomic diversity that not only exists between patients but also between cancer foci. And not all cancers that are present have the potential to kill. So, for example, if you look at this systematic analysis, we see that the all prostate cancer prevalence is about 50%. But clinically significant cancers, these are cancers that are likely to cause harms if untreated, it's about a third. So what is clinically significant cancer? Well, a tumor that is likely to cause harm is a clinically significant lesion. So the image on the top right, you can see a large cancer. And on the bottom right, you see a smaller cancer. Clearly, the larger lesion is the more significant tumor. But not always. Volume seems to play a part, but increasingly we find that it's the histological pattern and the presence of extraprostatic disease that's the more important factor. And the International Society of Urological Pathology, ISUP, now emphasizes these factors over the volumes when assigning significance to a histological cancer. So for patients who present with suspected prostate cancer, what are the clinical needs? First of all, we need to find out whether raises in PSA are due to cancer or due to other things such as infection. We need to reduce the total number of investigations, including MRI and unproductive biopsies, so we can reduce overtreatments of insignificant cancers. We need to improve the detection and the localization of significant disease so that we can biopsy them appropriately. And we need to do this in the fastest way possible and as cost effectively as possible. Now, the current pathway in most of the world does not incorporate lesion visualization before a biopsy. This is set to change in Europe in 2019. The problem with the lack of visualization before you do a biopsy, something that's now called systematic biopsy, is that a large proportion of men do not have any cancers diagnosed. These unfruitful biopsies can incur morbidities, but you can never be sure that there isn't a cancer beyond the needle that you didn't get. Overdiagnosis of clinically insignificant cancers can occur, but we know that when we diagnose these insignificant cancers, about 30% have a bigger cancer, which we didn't know about. So there is a degree of imprecision that is intrinsic to the way that systematic biopsies are performed. So the role then of imaging is to identify a cause for a raised PSA, if possible, such as infection or an abscess, to identify the location of a significant lesion so that an appropriately targeted biopsy can be performed, to distinguish between insignificant and likely significant disease, and to decrease the total number of biopsy cores that you can get while not compromising tumor detection and risk stratification. We do this by multiparametric MRI and MRI-directed biopsy. Multiparametric MRI is a method of evaluating the prostate gland using T2-weighted imaging, usually in 2 to 3 planes, diffusion sequences including an ultra-high B value, an ADC map, and usually dynamic contrast enhancement. These images are evaluated to issue a PI-RADS report, and oftentimes a diagrammatic report which helps communicate the presence, the location of suspicious lesions. For example, here is a suspicious lesion labeled as 1, and you can see that this is labeled as being 18 millimeters in size. It's given certain scores and then a PI-RADS category, in this case 5. A category 5 in the PI-RADS system indicates that a clinically significant cancer is highly likely. These categories are issued on the basis of criteria that we can see on the MRI images, including on diffusion sequences. So on the diffusion sequence, if you have a lesion that is more than 1.5 centimeters in size, or the presence of extraprostatic disease that is hyperintense on high B value images with a low ADC, that is a category 5 lesion. A smaller lesion, less than 1.5 centimeters, such as this lesion over here, that will be categorized as a category 4 lesion. And then a category 3 lesion is not seen on the high B value image, but is seen on the ADC map, or vice versa, but not both. Criteria such as these are then used to assign final PI-RADS assessment categories, which are these central categories here. So if you find a lesion in the peripheral zone of the prostate gland, the diffusion sequence is used to categorize the lesions from 1 to 5, except for lesion 3, where the presence of contrast enhancement enables you to upgrade a diffusion category 3 to a PI-RADS category 4. Let me show you an example. So here's a 56-year-old man with a focal lesion, obviously visible on the T2 sequence, but this lesion is in the peripheral zone, so should be assessed with a diffusion sequence. So here it is visible on the ADC map, but not really seen on the B1000 image. This is the 1600 image, where we can see some asymmetry, but this would be categorized as a PI-RADS category 3 lesion. But on contrast enhancement, you can see it's positive. There's a focal area of enhancement in the left peripheral zone, so the final category is PI-RADS category 4. For transition zone lesions, it's the T2-weighted imaging that enables the subcategorization. But you'll notice how diffusion imaging again appears and enables a lesion to be promoted from a 2 to a 3 and from a 3 to a 4 using the criteria that we just discussed. If you do it this way, you can see that the chance of having a clinically significant cancer is 6% for PI-RADS categories 1 and 2, 12% for PI-RADS category 3 lesions, and then when you look at 4 and 5, you can see the prevalence of clinically significant cancers increases from 48 to 72%. So you can see that the more suspicious you are, the higher is the likelihood of clinically significant disease within these categories. Now, of course, we are interested in knowing how well MRI does in relation to the normal way of doing it, which is systematic biopsies for all. So here's a randomized control trial where systematic biopsies are done for 250 patients, and these are the yields. If you do an MRI directed biopsy, in other words, don't biopsy negative MRI scans, only biopsy patients who have a positive scan, these are the outcomes. So what you notice is that 28% of patients avoid a biopsy after a negative MRI. That's 1/3. More clinically significant cancers, these are your ISUP 2 or greater lesions, 12% more. There are 13% fewer insignificant lesions. But look at the number of biopsy cores. 4 biopsy cores per patient compared to an average of 10 to 12 core biopsies with systematic biopsy. A number of systematic analyses have looked at this now, and what you find is that there is a slight advantage in biopsy-naive men of the detection of clinically significant cancers compared to the systematic route, but it's very marginal. But in patients who have had prior negative biopsies, there's almost a 30% improvement in the detection of clinically significant disease using the MRI technology. The more impressive result is the reduction in the proportion of indolent cancers that are detected. So in the biopsy-naive cases, you'll see there's a 40% reduction in the detection of indolent cancers. And in the prior negative biopsy group, there is almost a 50% reduction in the detection of clinically insignificant cancers. When we rank the strength of claims of the MRI pathway, the strongest claim is around reducing the number of patients undergoing biopsy, and this ranges from 30 to 50%. This helps reduce diagnosis of insignificant cancers. There is a potential for reducing the number of biopsy cores and biopsy-related morbidities without affecting the detection of clinically significant cancers. However, the claim of increased detection of patients needing active treatments, that's to say those patients with clinically significant disease, is only for the prior negative biopsy group. For the biopsy naive, this strength of claim is less strong. As a result of which, we find that in 2019, the EAU guidelines recommend the use of multiparametric MRI in all men, in other words, image-guided diagnosis and biopsy, and endorses the PI-RADS guidelines for both the acquisition and the interpretation of MRI scans. However, in the United States, we still haven't arrived at that point. So the NCCN guidelines of 2019 merely states that MRI should be considered, and MRI targeting can be considered in centers that have experience with MRI and MRI targeting. The reticence of the Americans centers around the quality of the scanners and the experience of MRI amongst general radiologists. So look at this particular example. Here's an MRI that was performed at 1.5T. Here are the diffusion sequences, the ADC map and the B1000. Here's an MRI scan performed at 3 Tesla. Here is the ADC map and here is the diffusion sequence. So you can see that this was rated as a PI-RADS 2 by a general radiologist because he's using a 10-year-old scanner at 1.5T. This has been rated as a PI-RADS 5 lesion because it was done at 3T and was done by a specialty radiologist. Targeted biopsies of the lesion on the right-hand side, this lesion here, showed a clinically significant cancer. And it's because of this quality issue between the diffusion imaging at 1.5T on an older scanner and 3T on a newer scanner that there is reticence about the uniform use of MRI for biopsy. Because of the quality issues for diffusion imaging, biparametric MRI use is considered controversial. Certainly, biparametric MRI has good rationale for use. Examination times are faster. There are reduced costs. There's minimum utilization of contrast medium, which of course reduces adverse effects. And many will point out that biparametric MRI can help to define negative cases and so reduce the number of men undergoing biopsy. This, of course, is the principal advantage of multiparametric MRI. And in fact, this has been shown by this recently published study. 4 expert centers, remember, 3 Tesla systems, in-bore MRI. And if you do that, you can reduce acquisition times dramatically. You can reduce costs by 50%. However, the number of intermediate scans, PI-RADS 3 cases, increases from 40 to 70. That's almost a 75% increase in the indeterminate cases. Now, in this study, at 4 expert centers, the PI-RADS 3 prevalence to start with was 6%. So a 75% increase would only take that number to 9%. But in most centers, PI-RADS 3 cases are about 20%. A 75% increase would take that proportion from 20 to 30% or more, and that may make the whole test unacceptable. More indeterminate cases will lead to increased numbers of biopsies, an increase in the number of clinically insignificant cancers, but because we perform more biopsies, so the detection of clinically significant cancers is unlikely to be altered, which is exactly what we see here. And in fact, if you look at meta-analyses, what you find is that biparametric MRI is not a significant contributing factor to heterogeneity. However, individual studies do show that there are differences in the sensitivity of biparametric versus multiparametric MRI. But we should really assess the biparametric MRI performance against the claims that we can make for multiparametric MRI compared to trust biopsies. We know how well we do against trust biopsies. We have to ask ourselves, do the same claims stack up for the multiparametric MRI approach? So the claim number 1 is reduces the number of patients undergoing biopsies after a negative MRI. Now, we know this to be the case with multiparametric MRI, but we have just said that there are more indeterminate cases, so in fact the number of biopsies does increase. The PI-RADS 3 category increases by 70% in one particular study. The second claim is that we reduce the diagnosis of indolent cancers because fewer biopsies are done. The answer is that even with biparametric MRI, we can match that claim, but we are not as good as multiparametric MRI because we do more sampling. Does it improve the detection of clinically significant cancers? We have already said that the multiparametric MRI pathway only has a marginal effect. And in fact, for biparametric MRI, there is only a marginal effect because we do increased sampling. And increased sampling does not appear to increase biopsy yields. The fourth advantage was that we can reduce the number of needle cores per patient in positive patients. This happens to be true for multiparametric MRI because truss biopsies and directed biopsies are the preferred option for biparametric MRI, which by itself increases the number of biopsy cores. So what does the PI-RADS committee say? The PI-RADS committee makes no specific recommendations on the preferred use of biparametric MRI. Instead, it says that when clinical risk factors indicate the presence of clinically significant cancers, in other words, cancers that should not be missed, do a multiparametric MRI. When you have had a previous negative biparametric MRI and the patient is at persistent clinical suspicion, do a multiparametric MRI. When you have technical factors leading to suboptimal imaging quality, for diffusion imaging in particular, do a biparametric MRI. And high quality reading is mandatory, and you can judge this by a low PI-RADS 3 caseload. If your caseload is approximately 20%, as it is for the majority, then do multiparametric MRI. If you are a super expert and your PI-RADS 3 case prevalence is in 6 or 7%, then you will not suffer that much by doing a biparametric approach. But expertise in imaging and in reading is mandatory if you are going to use the biparametric MRI approach. So here are my concluding statements. MRI can identify a large number of people who can safely avoid an immediate biopsy after a negative scan. Remember, a negative scan is defined by a negative diffusion sequence. MRI can reduce the detection of clinically insignificant cancers. MRI can increase the detection of clinically significant cancers, but only in previous biopsy naive men. MRI can work in practice if we accept that we will not find all clinically significant cancers immediately and have robust safety net monitoring in place. We do need to assure the quality of the diagnostic process. That's to say, the scan components, the interpretation, and the biopsy. We need to have safety net monitoring regimens in place and robust multidisciplinary working. Diffusion imaging is a key component for diagnosis that we need to get right every single time. And this is a physics challenge that still needs to be addressed. Thank you for listening. Hope you've enjoyed the video.